In this video, we're talking about two different things. We're talking about prostate cancer and we're talking about GLP-1s, otherwise known as weight loss drugs. So today I'm interviewing Kristin Geiger, and she is a nurse practitioner who specializes in prostate cancer. And she has a lot of experience using these drugs in combination with other prostate cancer drugs, and she's going to talk about the patient experience. So today we're talking about GLP-1s, and this has been a huge topic in the media. You know, we see all these like celebrities taking weight loss drugs, and now we're seeing it kind of, it went from diabetes into mainstream weight loss, and people have a lot of questions, especially when they're dealing with cancer, because we talk so much about diet and lifestyle. We talk about, weightlifting and really what are the lifestyle choices that we should be making. You deal with prostate cancer patients on a, in and day out basis. So when it comes to these types of weight loss drugs, how would you say that them as prostate cancer patients who do have a higher BMI can benefit from taking these types of drugs?
So we have a lot of patients that are doing well, like post-prostate cancer treatment. They potentially had been on hormone therapy, which makes it incredibly hard to lose weight, to manage your exercise. There's fatigue that comes with that. And so if patients have gained a little bit of weight or a lot of weight after treatment, it's a great time to say, hey, you're feeling better. This is behind you, but let's get you into the best possible physical condition that you can to live the rest of your life well and healthy and with, good energy and limit your risk factors. And so that's kind of one of the main points where we bring these types of medications in, is saying, if we're managing just watching going forward, we're just following up, you have no evidence of any disease. How can we improve your health overall? What's going to help you in the long run really thrive for the rest of your life? And looking into weight loss is one of those things that just puts you at risk. Weight loss helps minimize a lot of the risks that come with being overweight or obese.
What about for patients who are currently on treatment and do have those higher BMIs or even on hormone therapy? Do you ever put these types of patients on that drug?
It's potential that we could. I haven't found any interactions with the medications that we prescribe and the GLP-1s, but there's so much going on. We really emphasize exercise and strength training during treatment. They could go on it. I'm just scared to just throw so much on them that they become a little bit more just overwhelmed or feeling helpless or hopeless, trying to treat everything. There's just another drug. They're throwing all these drugs at me, and that can be really add a burden to patients when they're trying to grapple with, a disease that they've just been diagnosed with, or just the effects of being down while you're on hormone therapy. It's really patient to patient, what's appropriate for each patient, where are they at in their coping or their disease progression, for whether or not the timing is right for that kind of thing.
When it comes to a patient, taking these types of drugs, normally these are injections. So what is the dosage? And then do you find patients having an issue injecting themselves?
The starting dose that we do is the lowest possible for the one that we're prescribing. And so I like to start low, go slow, where you see how they deal with the smallest amount first. And so whether that's 0.25 or some of the other medications, it's a small amount. And I haven't had any issues with the injection so far. I sometimes teach patients how to inject, over video or in office if they need to. Somebody knows somebody in their family that's given an injection before, or they can, pull up a video and watch how to do it. It's pretty straightforward with the pens that they deliver and the instructions given. In terms of dosage, when we start on that lowest dose, we're really looking to see how well it's tolerated. And so I like to see a patient within 4 to 6 weeks of starting a medication, just to ask them about their side effects, to see, what's going on. And so typically what I've seen is a patient will have maybe a little bit of nausea, a little bit of acid reflux, because their stomach's not emptying very quickly anymore or as well as before. And so I'll ask them about that, and they're saying, oh, I'm feeling this a little bit. We'll talk about it. We'll see if they need to take anything or not to help with that. And then over time, that kind of goes away. And they kind of get used to the medication, and then we'll titrate up to the next, go from 0.25 to 0.5, and then those symptoms will come back again, and we'll talk about it. And then we'll go, they'll get used to it. That'll kind of go away. Going up slowly has really helped as the body adjusts to it. And then, the patient kind of knows what to expect. I think I've plateaued again because, I'm not feeling the effects anymore. I did have a patient, though, who it caused him to be a little bit nauseated. And he was happy with that, which was interesting to me because he was like, well, then I don't eat if I'm nauseated. And I'm like, well, you have to eat. But he did really well in terms of the weight loss on it. But for him, being nauseated was worth it. It was worth paying that to cut down on his food intake and to get to his goal weight. I'm not saying, if you're nauseated, you have to feel nauseated and stay on the medication. Please, let's talk about it. But it was helpful for him, and this was a goal, and it was pretty mild, but it was just something he went through, and he looked back on as, yeah, I felt that, but it was okay. And that was interesting.
Do you ever put patients on anti-nausea medications if they're taking this?
I haven't had to. He was a little bit more of an outlier with the nausea. Typically, it's the acid reflux that will say, maybe pick up some over-the-counter antacid first. Otherwise, if it's too intense, we can titrate down the dose or something.
So are there any other side effects that patients should be aware of besides the nausea, besides the acid reflux?
If you've been paying attention to the news right now, you've seen some of these people coming out and saying it causes the gastroparesis, which is the stopping of the normal movement of your stomach and bowel. I have not seen that. I think, there's probably a very, very small chance that can happen. That's not something that I overemphasize. I'm not sure if it's truly happening in multiple cases across, the country even. But in terms of other side effects that are a little bit more out of the norm, I do warn patients that there is a small risk for pancreatitis. Just the pancreas is what produces, insulin. And so when you're producing a little bit more, it can get irritated. And so sometimes we've checked the pancreatic enzymes just to make sure they're normal. I also say, if you have any stomach pain above your belly button, let us know. I actually haven't seen it, but it's a good also segue for me to say, are you drinking any alcohol? That also increases your risk for pancreatitis. It has a lot of calories. And so if you can cut that out at the same time, you lose calories and you lower your risk for pancreatitis. Other side effects, I think I've read, I haven't seen it, but some people have belching because there's more food. They're longer, you got a little bit of the reflux and the belching that comes with that. But I think that the fact that it slowly empties really helps you, because it's immediate feedback if you've eaten too much. Like, oh no, I've overfilled my stomach, and I feel full and I can't eat as frequently, which is good. That feeling of fullness, that will stay hopefully a little longer. You'll feel more full longer as well.
I think that percentages, or even just, 1 out of 3, 1 out of 10, really give context to, you probably aren't going to be that patient because it's a 1 out of 10 chance. So what would you say with the side effects that you mentioned when it comes to, let's just start with the acid reflux. What would you say? Is that like a 1 out of 5, 1 out of 10 patients?
I'd say at least 50% have a little bit of that from what I've seen. It's not all the time, but it is pretty common. Whether or not they already had a little bit of acid reflux, because we are dealing with, an older population who tends to already struggle with that type of thing, and that just makes it worse, or it's a new thing for them, it's probably about half the time we'll have, a talk and they'll say, yeah, I have a little bit of that, or, oh, it's gotten worse. And start with the over-the-counter. Well, have you tried Tums for it? Or have you, done an over-the-counter antacid, pill?
And what about the nausea?
It's much, much more rare. I think that one patient I mentioned, he's kind of maybe 1 or 2 of the 40, 50 we've been or seen on this medication. Maybe 2% chance.
And what about with any of the other things that you mentioned when it comes to the pancreatitis or even just the gastrointestinal issue?
I haven't seen that yet, really. Yeah. We've either been really fortunate not to see any of it, or it is a very, very low percentage, which I'm tending to lean towards. When you read a package insert or you hear anecdotes from a single case, you can get really scared. But when you're pulling from a pool of, I prescribed this, we started a low dose, you're going to really limit the side effect profiles.
So, when you're talking about these injections, are they typically in the stomach, and are they weekly?
Weekly into the stomach. There's a little irony there where I say, it's a subcutaneous, it's going into the fat. Most people have a little bit of fat on their stomach, and they always laugh because that's why they're getting this medication, is because they have a little bit too much fat. And typically it's the fat that is around, the stomach or the belly that has the worst health risks. And so I'm like, most people do. You can just put it right in your stomach, and they're like, I have some there, yes. And it's not been an issue.
Typically patients are, a lot of times they have comorbidities and they're on other medications, and then they go and take a semaglutide. So are there any counter interactions where you're going, if you're taking this, don't take this? Maybe there's a heart issue, maybe there's a previous, health issue where they're not eligible for this. Is there any criteria that patients should know about before, maybe they're going to have these conversations with their doctor and he's going to say no for certain reasons? Is there anything you've seen?
2 absolute contraindications, and one of them is any family history of medullary thyroid cancer. And the other one is, I think it's called MEN2, which is a endocrine syndrome. And so I will ask patients, just to say, hey, if you have any of this in your family, I'm not going to give it to you based on the data, based on the package insert. And I haven't come across anybody that's had that. I did have a patient who was adopted saying, I don't know. And so then we kind of talk through, risks, benefits, in terms of how likely is there to be that in your family history too. But otherwise, I haven't seen true drug-drug interactions. I'd have to look it up, but every time I prescribe it, I do go against and I check drug-drug interactions with every single medication they're taking to make sure that it's safe.
So as far as duration goes, after you do the follow-up for 4 to 6 weeks and you're increasing, doing the dose escalation over time because the patients are adjusting to the drug, what duration have you seen patients be able to stay on it? And does that match up with, is it really determined by how much insurance will cover it? Where do you see the ending?
I like to tell them to give it a good 3 to 6 month try. Within 3 to 6 months, we have seen up to 30-pound weight loss. And so even within the first couple weeks, if they're not telling me, oh, the scale's budged a little bit, I get a little bit like, maybe this isn't really going to make a huge difference for them, but it's worth trying for a more extended period of time. There was an insurance reauthorization that came through. I think it lasted either 6 months or a year. And so we would just have to resubmit for that patient for that medication that we had prescribed, and I think they would cover it again. The authorization isn't lifelong, but I think we can keep getting it reapproved, as needed. I do tell patients, though, if you're going to be on this medication and it's working for you, we're going to get you down to, your goal weight. We'll do a calculation of what's your ideal body weight, what's a realistic first goal that's not going to just overwhelm you, so you can kind of have these benchmarks. What would be, ideal versus what is a good goal? And so we kind of talk through that, and then we say, well, we'll prescribe it and see how long it takes you to get close to your goal. And then in some ways, some patients might need to be on it longer term, just to block that food craving that people are kind of just always oriented around food and towards food, and that can really help with that. But I am of the opinion if we can help heal or improve quality of life, ideally we could take you off of it. And so I tell patients, it's too soon to really know the ends and how we treat people at the end because it just got approved. But my goal would be to titrate them back down off of it. And so we talk a lot about lifestyle change too, because I don't just prescribe a medication like this if they're not motivated to change their lifestyle. And so we talk through, tell me about your physical activity, tell me about your, the foods that you're consuming and the choices that you're making. Are you walking? Are you lifting some weights? Are you eating enough protein? And so if they're not also making those changes, this is going to have a benefit, but it will not be maximized.
So what about in situations where, maybe they have come off the drug and they're gaining the weight back? How often do you see this happen? And is it an automatic if they're not going to make those lifestyle changes?
I wouldn't say that it's automatic, but it's not unexpected if they haven't made the lifestyle changes. I tell people they took 10, 20, 30 years to get to this point, so they're going to have to put in time to get back to being of a healthier weight. So I had a patient recently go off of it because he had, been very successful on the medication. He was doing well. He'd made a lot of changes. We slowly took him off and he gained a little bit of weight, and he was motivated enough to be like, hey, should I go back on it a little bit just to get my weight back down? Should I, what should I do? And we had that discussion of, okay, maybe if you want to go back on it for a month or two, that would help. But, what did you do differently in your lifestyle that caused you to also gain some weight back? And so, he said things, and I quote, like, I'll be good again. So he had also taken responsibility for not doing the right, abandoning his, commitment to his own health in some ways too. I think he did go back on the injection for a little bit and then he went back off of it, and he's actually doing well. He's maintaining. And so for him, he, made the changes and it's been effective. So he didn't bounce back. You watch videos where they rebound and you say, oh, well, it's just gonna come right back. And so my counter to that is, it might if you've made no lifestyle changes, or it might come back slowly, or we can leave you on the medication a little bit longer or titrate you off it to make sure that it won't rebound like that.
Cancer patients, they're on, as we've talked about, they're on so many drugs. They basically want to know, if I lose weight, and I get this question time and time again in the comment section, especially on our lifestyle and diet videos, if I lose the weight, if I take Ozempic or Wegovy and I get rid of it, will it make the treatments work better?
I don't know that there's any data that would suggest yes or no. Anytime you're healthier in general, your immune system can be a little bit more effective. So I'm not going to say that it wouldn't help potentially, but there's absolutely, no proven correlation between it. But as you feel better, you live longer overall too. And so if your body is doing better overall, I would actually anticipate your overall survival to be improved a little bit. You can weather treatments better. You have more of a strength reserve if you've been lifting weight, or the ability to get here and get there and not decondition as much.
I know another question that a lot of patients have asked about is there's kind of this unknown of, since it was just approved, and they have heard issues in the news because it's such a big topic. It's covered by the media. We have, interviews and all sorts of things coming out left and right. What about this concept of the unknown? Like, what about the things that we don't know? Does it cause thyroid cancer? What if I lose the weight and I gain it all back and it makes it worse and I have an uncontrollable appetite now? There's just a lot of overarching concerns that I've seen a lot of people who could use it just say, I don't want to do it because of this.
There is wisdom in waiting to see how things play out over time, but the rigorous way that the FDA requires testing and clinical trials gives us some surety that they wouldn't have approved it if it didn't make a difference and it wasn't overall proven to be a safe medication. They've been testing this for years to get to this point. And so leaning into that and saying, if they approved it, I think our FDA is more strict than some of the other governing bodies. They would jump through a lot of hoops to get here. And so in some ways that's reassuring. Am I just using that as an excuse not to give this a shot? No pun intended. Am I just saying, oh, that's for other people, I'll just wait and see while your health is just getting worse? And so you just, is this weight worth that risk of taking a medication to lose it? And each person is an individual and each case is individual. And so I'll set someone down and say, this did just get approved. I can only tell you what we might do in the future in terms of bringing you off of it and what when you're off the medication, it might look like. But are you motivated enough to make the changes now, to lose the weight now, to do all the different things this is going to require? And this can just be a boost to that. I don't like to prescribe it if patients aren't serious and if they're not willing to make other changes at the same time. It's really up to each person and their comfort level. But some people are using it as an excuse to just not do anything. And some people, it's a valid, I have a patient just being like, I do not want another prescription. I'm like, I understand that. It just seems like doctors throw medications at people without addressing a root cause or, the reason they got to that point in the first place. And so if I have a patient, that comes in and looks like, we're talking about it and their health goals and they haven't made any changes or they haven't even attempted to lose some weight or become more healthy in any capacity, I'm like, you might not actually be the right candidate at this point. It's hard and difficult to really have, that weight budge for them. And so we have those discussions, and I have definitely just said, no, you're not, I don't want to have you try it because there's so many things you can do first too. And you need to prove that you want to really make a difference in your health.
So you're a nurse practitioner who's dealing with prostate cancer patients all day, and now you're dealing with this whole world of GLP-1s. So how are you, advising patients with their diet about how to get proper protein intake if they're not taking in animal products.
Thankfully, we live in a day and age where there's a lot of good alternates and there's a lot of accessibility to other types of proteins. We have a Whole Foods, we have Trader Joe's, we have so many good tasting food that's from all different types of sources. And so it just takes someone willing to walk down one of those aisles and look for the protein intake on the back of a package. But you're right, when you're on a weight loss program or medication, if the goal is a caloric deficit, your body's just going to start burning what it's stored, and it's going to burn fat, but it's also going to burn muscle. And we don't want to lose the muscle. We talk about muscle building in prostate cancer all the time of you need to do strength training. We ask every visit, every patient pretty much. What I do with this, when I add this to those prostate cancer patients, is you need a trainer and you need adequate protein so we don't lose the muscle. And I know that I've seen that as I've read some articles about, the semaglutide and what it does. And so people complain about, I lost weight, but I lost half my muscle mass. And I'm trying to prevent that from happening by really emphasizing protein intake and just, take a walk down a health foods aisle and look for alternate sources that are not necessarily the red meats or the chicken, which is a good lean, protein. So it takes a little bit more work.
I think one of the things that stood out to me regarding GLP-1s and what Kristin said is how much quality of life matters and how it's really important to be vocal about what you're experiencing when it comes to side effects and when it comes to just your prostate cancer situation. If you have concerns or you're wondering about whether a treatment is right for you, make sure that you're coming in with your questions and that you're talking to your doctors and really talking about what your concerns are. Write them down throughout the week and get super vocal about what you're going through. It's really important. If you need help, learning about your prostate cancer diagnosis or need more information on anything we talked about in this video, you can contact our helpline at pcri.org/helpline. These are prostate cancer patients who have been through a lot of the situations that we talk about, and they can help you kind of formulate questions and information for your medical team so that you have a better outcome and come in knowing that you are empowered with the research that you've done and you can ask the right questions and get the right answers. If you would like more information about prostate cancer in general, you can visit our website at pcri.org. Please don't forget to click that subscribe button, and please remember, most of all, you're not alone.